Hello, everyone, and welcome to today's webinar, Trauma Verification's June Q&A Web Conference. For best sound quality, we do recommend that you join by phone rather than computer. I would now like to introduce Megan Hudgens, Trauma Verification Program Coordinator.
Hello, everybody. This is Megan Hudgens, one of the program coordinators for the VRC, and thank you so much for joining our webinar today. And just a quick introduction of some of our trauma quality program staff. Tammy Morgan, our manager of Trauma Center Programs, is not here today, always here in spirit. Molly Lozada is in the room and might chime in at some point during the presentation, but the hosting duties will be primarily turned over to myself, Megan Hudgens, hi, and Bhumi Parikh, my co-coordinator, who will be chiming in for the general questions here in a few minutes. So a quick note on continuing education. To qualify for CE, you must attend at least 50 minutes of educational content. An email will be sent to all attendees who qualify for CE within 24 hours of the webinar ending with instructions on how to claim CE. And as always, if you have any questions at all, please don't hesitate to email us at coTvrc@sacs.org. So what's the goal for this webinar? Firstly, to interpret the standards outlined in the Resources for Optimal Care of the Injured Patient Manual to ensure that hospitals have an understanding of the criteria to provide quality care to the injured patient. And secondly, to understand the processes and standards involved in an ACS trauma verification site visit and how following these will positively impact the quality of care of the injured patient at your trauma center. So let's get started. So first, the Orange Resources book. This is available as a hard copy or a PDF version, and we always recommend that you have a copy available, either a digital or a hard copy, to refer to during the presentation, and especially during the CB-related questions section towards the end of the webinar. And also in conjunction with the Resources for Optimal Care, you're going to want to use the most current edition of the clarification document and the verification change log, and both of these you can find at the link at the bottom of the slide. So the clarification document and the verification change log, as you know, these are released monthly. The change log, as the name implies, notes any criteria changes or updates, and the clarification document provides any necessary elaborations on existing criteria. And again, these are available for downloaded at the resources repository. Pardon the construction noises, by the way. So website resources for trauma centers. So we have a few of these. We try to run through them once every webinar. We do have recordings of webinars, and these go back pretty far. These go back to June 2016. So cue them up in your car, listen to them on your way to work. We have your binge listening covered for the foreseeable future. The stakeholder public comment website. This is a space for you to provide your feedback about trauma verification criteria on an ongoing basis. There are surveys available for every chapter in the Orange Book. So if you have any particular comments or concerns or suggestions, please do let us know. We do ask that these be evidence-based suggestions wherever possible. So if there is particular specific scholarly research or studies that correlate to your comments, please do throw that our way too. So we do have a couple of tutorials produced by Molly Lozada. One of these is regarding the first steps for becoming a trauma verification or a verified trauma center, and one is about the site visit process. And again, you can find both of those on the link on the slide, and the participant hub. So be sure to log in and update your contacts when you can if you have had a staffing change. TPM, CEO, please try to keep these updated, especially the CEO. Frequently, these aren't automatically in the system, so we do tend to, when we send the final letter and final report, we do send this to the TPM, TMD, and either the CEO, COO, nursing director, hospital president, someone in an administrative role. So please try to keep that contact up to date as well. And also the expanded FAQ. So this was actually just revamped and condensed along with the clarification document and change log to align the information contained in those 3 documents. We encourage you to please take a look. We spent so many hours on this document and want to share it with you. And moving on, quick disclaimer. All questions are pulled directly from the question submissions. There have been no edits made to the contents, so not to pressure you to proofread, but just your friendly warning that these questions will live on the internet forever. If your question is not answered today, the question may require more information and will receive a response from ACS staff within 1 week after the webinar. So scheduling reminders. We actually do this every other month. So these will be presented by Rachel Tanchez, our scheduling coordinator. And the next presentation on scheduling reminders will be in July's webinar 2019. And a few quick announcements. So call for data. The TQIP quarterly call for data is now open. In this call, please submit your first quarter of 2019 data, as well as any updates to previous submissions dating back to the first quarter of 2017. And the call for data will close Wednesday, July 10th. And the next verification Q&A webinar, the webinar date will be Wednesday, July 31st. The webinar time will be 12 p.m. Central Time, and the deadline to submit your questions will be Monday, July 8th. And if that question submission deadline seems pretty soon, that is partly tying into our next announcement. We are going to be launching a new webinar platform. So starting July 2019, the webinar will be presented on a new platform. So what does this mean for you? Basically nothing. The registration and question submission process is going to be exactly the same. We will be sending out detailed instructions through email. And since this won't be a live show anymore, there won't be an option to call in by phone. So you're going to listen in on your headphones or through speakers via computer. So what I think y'all are going to be really excited about, you don't have to clear your calendar anymore so that you can sit in on this 50-minute show to get your CE. There will be an eligibility window through which you'll be able to watch the archived webinar video, and the expiration date for you to watch and collect your CE will be communicated through email and on the ACS website. And this also means that we get to pre-record this whole show from the comfort of our in-office recording studio, so really everybody wins. So one good thing about these webinars, we're just not getting as many questions as we used to, which really means we're doing our job right and answering your questions. But it also means that we're ready to start building on the Q&A structure of these presentations and start adding some additional content. So by all means, let us know what you want. Feel free to shoot us an email. You can reach us always at cotvrc@facs.org. And just let us know your suggestions. We've been batting around a lot of different topics. Future segments may include a discussion of the alternate pathway, for example. We could do specific drill downs into the chapters of the Orange Book and possibly the peer review process for your verification report. So any of those are on the table. Just let us know your thoughts and if there's anything you would like to see in the future. And speaking of which, we have a segment this month on PRQ validation. So what is this? So this takes place after the submission of your PRQ. So this will be within that last 30-day window prior to your site visit. The VRC office will review each PRQ once it's been marked complete and will contact the TPM if necessary to verify, firstly, that any deficiencies, to verify any deficiencies that were automatically flagged. And to clarify, this doesn't mean that you definitely got a deficiency. The way the system is set up, certain answers in the PRQ will flag a potential deficiency in our internal system. So frequently this is due to a mischecked item in the PRQ or a question that was skipped. And a good portion of the time, we really just need some additional information. Once or twice it's even happened where, for example, someone put a non-numerical character in the PI attendance table in Appendix 2. And because the system reads everything other than 0 to 100 as an invalid entry, it flagged a CD. So things like that. Most of the time, we really just need some extra elaboration. So consistency of data in the Chapter 2 data tables. We're going to get into that in a couple of slides. All necessary data and information for the site visit is present, self-explanatory. So why do we do this? Why are we sending you this email telling you about all these things we need to correct and stressing you out when you're getting ready for your site visit? Well, there's a few reasons. We want to clear up any confusion well in advance of the reviewers arriving on site. We want to ensure that the reviewers arrive with the most complete and accurate illustration of how your trauma center functions. And we want to clarify inaccuracies on the front end of the review, which is going to allow for a swifter and more seamless editorial process for the final consultation and verification report. So guys, at the end of the day, it's going to be quicker and less stressful to resolve these questions or concerns 3 weeks out, 4 weeks out from your site visit. And it means that there's less we have to resolve on the back end to get your final report to you as quick as we can. You might have heard that our turnaround is down to around 25 days, partially because of this process. So, common corrections. So this is related to the section purpose of site visit and how it connects to certain questions in Chapter 10, the pediatric section. So one red flag for us in purpose to site visit, we have a question, screen cap below, facility treats what type of patients? And there's 3 options there, adults only, adults and children, or pediatric only. So frequently for centers undergoing adult verification, they will check adults only, even if they did admit some pediatric patients during the reporting year. And this could be 8, 25, 100, it could be any number. But the concern would be, oh, well, we're only going for level 1 adults, so why would we need to fill out the pediatric section? So this is the thing, you're going to want to select adults and children if you admitted any children at all. It doesn't mean that you necessarily have to complete all of Chapter 10, but there are a few questions that we're going to want to have answers to. Specifically, and we have this broken down here, Section A, Question 1, and that's going to be the age of the pediatric patient at your facility. All of Section B, which is splenic injury in pediatric patients, and Section C, which is going to be just all of your pediatric data, ISS breakdown, non-surgical, etc. And some more common corrections, level 3 neurosurgery. So if you're seeking level 3 verification, please make sure that you tell us in your PRQ if you provide neurosurgery care, because it happens sometimes where this question gets left blank, and what happens then is that the PRQ will read the answer as a no, and it'll generate only the questions in the neurosurgery chapter that apply if you don't provide neurosurgery care. Then we take a closer look and find, like, wait, they had the truncated version of Chapter 8 for not providing neuro, but then they go on to mention a neurosurgery liaison or neurosurgeons on staff. That's another flag for us to check in with you. Chapter 8 of the PRQ is basically completely altered based on how you answer this question. So Chapter 9, open tibial fractures, real quick one here. Just be sure as you're filling out the time to washout of open tibial fractures that you provide the average and the range. So the example we have below only has one of the 2 fields that we need. So there would be an average, the 192 minutes, for example, and then there would also be a minimum maximum range for time to wash out. And going back to the Chapter 2 data tables, we do bring this up from time to time. It's probably one of the things that we have to validate most often. And basically, there's the 5 tables here. There's certain segments that need to line up, and the color-corrected numbers need to match. So, for example, the total number of admissions, in this case, 1846 from tables 5 through 7, and then it jumps to 1871 in table 11. Like, these need to match, or we need to have an explanation for why they don't match. Trauma service admissions, the red color-coded item. Frequently what will happen, because of how table 11 is structured, you'll see how the far right column, number admitted to trauma service, follows after total number of deaths. A lot of times what will happen is that centers will think we're asking for the ISS breakdown of trauma service admissions who were also deaths. We actually want the ISS breakdown of all trauma service admissions. And then lastly, the green color-coded item, non-surgical admissions. Just double check in Chapter 8 that the sum of that first row adds up to the non-surgical admissions you provided in Table 7. And in general, we recommend just going through and double checking with a calculator to make sure that all of your arithmetic adds up, because we do have every now and again, oh, we meant to add in like 1064, but we meant 1065. So just, go through, double check your numbers, make sure they all add up. And with that, I'm going to turn this over to Bimi Parikh to go through some general questions.
All right. Hi, everyone. I'm going to be presenting on the general questions for this webinar. So we can go ahead and get started. So the first question is on trauma reporting structure. Our administration is trying to move the reporting structure for trauma from surgical services to emergency medicine. Is there any verbiage to prevent this other than trauma is a surgical service? It would be good if the ACS would require level 1 and 2 centers to be under surgical services to prevent this. So we don't specifically have any standards associated with the reporting structure, but what we want to see is that the reporting structure allows the TMD and the TPM the ability to run their program, and it allows them to address issues across the spectrum of the hospital. So we do have a couple examples of the organizational charts in the next couple slides that indicates this relationship. So as you can see in this organizational chart, the TMD and the TPM have a direct correlation. So they have this direct line of communication available to them. Similar to this slide as well, the TPM and the TMD have this line that allows them to continue to make or continue to be able to communicate regarding other things that are related to the trauma center. And then similar to this organizational chart as well. So the next question is on type 2 deficiencies. Is there a limit to a number of level 2 deficiencies a facility can have and still be verified as a trauma center? So yes, there is a limit. So if there are up to 3 type 2 deficiencies that are identified during the initial re-verification or verification visit, the trauma center will be verified for a period of 1 year. So if more than 3 type 2 deficiencies or any type 1 deficiencies are present at the time of the initial re-verification or verification site visit, the hospital will not be verified. So in that case, if they are not verified at all, they would need to schedule another verification or re-verification visit after that. And then if there are any type 2 deficiencies, a successful focus review, whether on-site or focused by mail, would be required in order to achieve the additional 2 or full verification period. So for type 1 CDs, that's usually in Chapter 16, which are related to PI, that will usually require the on-site focus visit. Antibiotics. Antibiotics given for open tibia shaft fractures only. And then another similar question was, when referring to the standard of administering antibiotics within an hour for open fractures, does this only apply to open long bones? What about open nasal fractures, fingers, etc.? So this is for verification purposes only. So the data that we're requesting in the PRQ is for only tibial shaft fractures. So don't include any ankle, pilon, amputations, plateaus, nasal, or finger fractures for this number. Another question on open fractures is, it would be great if TQIP and VRC keep moving forward toward aligning definitions, for example, how open fractures are dealt with, only tibias versus all open fractures, except maybe ribs. So yes, we are aware that these definitions don't align at this point, but with the next revision of the Resources for Optimal Care manual, we are definitely looking to align these definitions with NTDS and TQIP. Alternate pathway. Is there an alternate pathway for ER MDs who were previously board certified but did not renew because they're close to retirement? So no, there is not an alternate pathway for these physicians. So keep in mind, alternate pathway is only for those folks that are non-US or Canada trained. So for this specific instance, if the physician is not current in their board certification,
they would need to be removed from the trauma call panel in order to maintain compliance. So they can see other patients, but just not trauma patients. Isolated hip fractures. So clarification regarding geriatric isolated hip fractures. Last webinar, it was mentioned that these patients should be reviewed for non-surgical admission or death if applicable. In our region, these patients are not included in our trauma registry inclusion criteria. Thus, they are not seen by the trauma service, are not reported to NTDB, and also not tracked by our PIPS process. Are you expecting us to PI these cases even if we don't see them and don't keep track, report their data? So we definitely understand that these patients, or the inclusion of these patients will vary based on the institution's policy on admission and the state inclusion criteria. So for this specific instance, if your trauma policy excludes these patients and are not reported to NTDB, you would not track and report this data. So a little bit of a long question on non-surgical admissions. So can you please clarify a review of non-surgical admissions in regards to what is in the Orange Book and on the PRQ? The Orange Book, page 121, says that we need to review by exception, i.e. those patients who did not have a surgical consult, single level fall or drowning, poisoning, or hanging, or ISS less than 9. All remaining trauma patients admitted to a non-surgical service should be reviewed, but the PRQ doesn't state that. We have looked at both the clarification document and the change document, and we do not see this addressed. We were cited at our re-verification for not having documentation on every NSA, even those with multiple surgical consults. So this is a question that we get quite a bit. So to clarify, a deficiency will not result by having a high number of non-surgical admits. The deficiency will only be cited when the center has a high number of non-surgical admits, which is greater than 10%, and does not review the cases to ensure the patients received an appropriate surgical evaluation. So what is being referred to in the Orange Book on page 121 is a specific metric on how and when to perform a review of the NSA. So based on this metric, the first PRQ asks if the center admitted greater than 10% of non-surgical admits. So this is a yes or no question. And then the second question that follows is, was a PIPS review done by the TPM and TMD? And what we want to see here is that the answer should always be yes here. So typically, all the NSA cases are reviewed in some fashion by the TPN, and if they are not, then deficiency will result. So if the center is unable to demonstrate or provide the reviewers with the documentation on how these cases were reviewed, it will be cited as a deficiency.
So this is Molly. I just want to interject about the non-surgical admissions. And I know this, as Bhumi said, this question comes up quite often, and I am waiting to present a tutorial on this in the near future. But again, we just want to clarify. I know some folks get concerned if their non-surgical admissions are greater than 10%. And as in one of the other slides presented about geriatric hip fractures, a lot of that can be based on those types of admissions. But again, that's based on your trauma hospital admission policy. But in this case, the deficiency is not on the 10%, and we are working in the revision process. As a matter of fact, we are looking at this specific standard currently in the revision process about possibly removing that threshold and just considering just making it super easy and having, as we recommend, reviewing all non-surgical admissions, but more information will come as we wrap up that chapter in the discussion.
All right, thanks, Molly. So the next question is on OPPE. So who should complete the trauma medical director's OPPE? So this was kind of seen in the organizational chart that indicated that the TMD usually would report to the chief of surgery. So, but however, this will vary by institution who will perform the TMD's OPPE. So typically it would just come from the med staff or the chief of surgery. So the next question is on pediatric admissions. So as an adult center, if we admit more than 100 PEDS patients a year, do we have to have a dedicated PEDS program staff or just PI points? So to clarify, centers admitting pediatric patients are not required to be a verified pediatric center, but as per CDs 2-23 and 2-24, adult trauma centers admitting more than 100 pediatric patients per year must demonstrate the presence of the following items. So what we would want to see is like credentialing of the trauma surgeons for pediatric trauma care, so whether that's PALS or whatever credentialing process that your institution provides, as well as a pediatric ED area, pediatric intensive care area, as well as the appropriate resuscitation equipment. And what we would also want to see is a pediatric specific PIPS program for this. And this is, once again, if your center admits more than 100 pediatric patients per year. So the next question is on PI charts. Is it best to pull charts with PI concerns to showcase our process for resolution and prevention? So what we infer from this question is that we assume that it's referring to a focus review. So if this is referring to a focus review, in preparation for it, we want to see you include charts that contain PI discussion in order to demonstrate PI process to the reviewers. So on the other hand, if this is not regarding a focus review, but preparing for a verification visit, we do want you to pull charts where an issue was identified and the center made improvements to address these concerns. So the next question is on PI forms. Are there any ACS specific forms used to capture PI to the college's expectations? So unfortunately, no, the VRC does not have any specific forms for this, but we do suggest like a few different methods to capture or to PI, such as customizing your trauma registry audit filters, performing random audit or chart audits, reviewing all deaths, of course, and performing concurrent PI. So another question was on deaths. So define means of reporting deaths in the PRQ, please. So DOA without signs of life only, death in ED, and death in hospital. So just to note, the VRC does not have any specific definitions for death on arrival, death in the ED, and in-hospital death. So these would all be determined by the hospital or your state's regulations. So in completing the PRQ, you would only use the death data based on your institution's definitions. So we have several questions on research this month. So the first question was on publications are a result from work related to the trauma center or the trauma system. And this person was seeking clarification on that. So what we want to see is that the research publication must involve members of your trauma program and result from data collected at your facility or within the health trauma system. So that includes your facility's data. So what we want to kind of see is just like, it has to include members of your trauma program and it has to be data from that, from your trauma center. So two other questions on research as well. So is it acceptable to include research published by an on-call physician based on the data from another center? Is it mandated that the research studies need to be based on the center's own data? So to answer the first question, no, this would not be acceptable. So once again, what we want to see is that we want to see that you can use, well, the center may only use research data from their own facility and own providers to meet the level 1 research requirements.
And just a quick clarification, because this also has come up in prior webinars or in prior email, someone asking if a provider has left their institution. If you flip this question around, if the provider has left the institution and did research at that particular institution, that research article can be used. So again, it's just the opposite of what this person is asking. And again, that would be acceptable for the other trauma center to use that publication, even though that person is no longer there, because the data resulted from work while that provider was working during the 3-year cycle.
So last question on research. Our program mentors a critical care fellow 3 months out of each year. Does that count toward the alternate research method? So yes, this would suffice as one of the 7 scholarly activities for the research alternate method. So if you refer to page 145 on the resources manual, you would see that there are 7 other like requirements per se that you would need to meet. And then, so as a reminder, for the alternate research method, you would need to satisfy 4 of the 7 requirements. So the next question was, when do you anticipate the Cranberry Book coming out? When would sites be required to meet the criteria in it? Will there be a PI coordinator requirement in the Cranberry Book? So yes, chapter revisions are currently ongoing, so we do not have a firm release date on the new edition or specifics to provide regarding the exact changes, but we will definitely disseminate any of that information as soon as it becomes available. So as some of you probably remember, as with the transition from the green to the orange manual, there will be a 1-year grace period from the official release of new criteria to give centers the opportunity to adjust and implement the changes. So for instance, if we release the new book early 2020, we would expect the site visits occurring in 2021 to abide by the new book.
Correct. And I was going to say, I was present when obviously when the green went to the orange, and what we do, we will establish a cutoff date. So we did it for the transition of the previous manual, and that really worked out well for us. So trauma centers had an opportunity to decide what version of the manual they would prefer to be surveyed under. So again, we're going to provide that opportunity for trauma centers when the book becomes available. I did want to talk really quickly about the chapter revision process, and I just want to let you know we're moving in a really good pace right now. So we're making some really headway on hopefully completing the book in the very, very near future. Again, as Megan reported, we don't have a release date of when that book's going to be done or released. Just like we did, if there's any, I know there's been a lot of questions about the PI coordinator and about the trauma registry, the number of data entries, et cetera. I know those are very, very important and critical criteria to trauma centers. So we are working on defining that and clarifying that and getting those approved, because there is a process to our chapter revision. It's, we wish it was super easy where we, have an agreed consensus, but it does go through a vigorous process here at this end. But should anything that the executive committee feels that would impact or benefit the trauma center immediately, such as what we did with the external trauma related CME criteria, they will allow us to release that information sooner than later, basically like one standard at a time. If that's the case, we certainly, again, will provide trauma centers the opportunity to, the time and the opportunity to implement those changes. And again, we are very aware that there are some critical criteria that trauma centers really are waiting on and kind of holding resources for. And again, we'll make that known when the time comes.
Thanks, Molly. Also, I don't think we decided on a color, but I do love cranberry though. So the next question is on focus site visits. So scheduled for a focus review in September because of a type 2 deficiency. Please explain the severity of a type 2. So I know we kind of covered this in the beginning, but while a type 1 deficiency will automatically result in the trauma center losing verification status, a center may have a total of up to 3 type 2 deficiencies while still maintaining a 1-year verification status. It is important to note that all deficiencies represent an issue that must be corrected in order to gain or maintain full verification. So just wanted to provide a little update on focused site visits by mail. So there are 2 types of focus reviews that can occur, and that will be focused by mail, and then the other one would be focused on site, where a review team would actually go out to the site. So for this, Molly was working on a focus by mail tutorial that she will be releasing soon. And this will basically cover like the basics of like why, or like what do you exactly do in a focus by mail, and like what kind of information will be required, and for what kind of CDs that will that usually occurs for, because there are going to be some CDs that are focused on site will be required, and then there are some CDs that can usually be corrected with documentation, so that's a focus by mail. So, so some common questions that we usually get are like, when is my corrected documentation due? And then this is usually reflected in the verification letter. So, and then where should you send this documentation? So we also get this question a lot, and then we just want this document to be sent to the COT VRC at FACS inbox. And then I know that some centers usually try and send us a hard copy. We don't necessarily need that, but if you just email it to us, we'll get that probably much quicker and save a lot of paper too. So yeah, Molly's going to be working on that tutorial, and it should be released soon. So the next question is on the site visit report. Is there somewhere that provides example scenarios of reports the ACS will ask the registrar for to practice for a site visit? So unfortunately, no, since this will vary by the reviewer. But for example, sometimes the reviewers will ask for reports for the last 3 to 6 months for patients with an injury severity score greater than 15. Or they may even ask for something like, oh, can you pull the last month's report on acetabular factors? So another question was for site visits and combined programs. So site visit in December for peds and adult, new and for release, states added surgeon for peds. Do we need separate dinners now? So this was mentioned in the May newsletter. So a separate dinner is not required for this. However, keep in mind that having one dinner for a concurrent level 1 adult and a level 1 pediatric review may run a little bit longer. The next question is, if site visit is for peds and adult verifications and state requires nurse reviewer, do we need 2 nurses? No. So the same nurse reviewer can serve on both site visits if they are being done concurrently. Another question was, when do you verify the exact dates of the consult or site visit with the facility? So confirmation of the site visit dates, regardless of the type of visit, will be received 120 days, so approximately 4 months prior to the requested date. The next question is on staffing changes. If your TPM, TMD, and registrar change in a 3 to 6 month period, does ACS require notification and a consultative visit? So for this, the ACS will not require a consultative visit, but we would advise notifying the VRC office, our inbox, as soon as possible, and also updating all current contact information in the Trauma Quality Program Participant Hub. So this is important since if your participant information is not current, then we aren't able to relay information regarding the webinars and the CE related. So then the next question is on transfer agreements. Are we required to have written transfer agreements for survey purposes? So yes, as required, the center must have transfer plans in place regardless of an impending site visit. So please have any and all transfer agreements for trauma patients in written form and available at the time of the site visit. So the next question is on transfers of patients. Can the care of a patient be transferred to the medical service before 24 hours with a documented tertiary exam? So for this question, there are no guidelines of when care of a patient must be transferred to another service. So the next question is on trauma activation. So this is kind of a lengthy question. So it's basically saying that a patient falls 25 feet, EMS is on scene and notifies ED that patient has AMS. The patient arrives without formally being activated as a level 2, but is worked up by the ED physician, goes to CT, lab is completed, and the ED physician calls the trauma surgeon after results show acute traumatic injuries. The process takes less than 1 hour from the time of patient arrival to trauma surgeon arrival. Can you put this patient in the registry as a level 2 activation because the trauma surgeon came to assess the patient? Can you charge this as a level 2 activation if it was not formally activated as a level 2 upon arrival of the patient? So the entry into the trauma registry will be based on your policy, but without having more specifics of this case, if the patient was not activated from the field, but was activated once the results showed an acute traumatic injury, this patient may be entered into the registry. But if the patient was not activated from the field or from the time the results showed an acute traumatic injury, this patient may be entered into the registry and identified as an under triage. And then in regards to billing, the VRC cannot really speak to that. So this was a good question on burn. So if a burn patient is activated as a trauma and our trauma team turns care to burn service, are they entered into our registry? If there is a burn patient that is transferred to our facility and meets our inclusion criteria, but our trauma team does not treat the patient, do they go in our registry? The other question that has been brought up was if we decide to put all burn patients in our trauma registry, is that data used for ACS reports? Should this data be marked as non-uploadable and only used for our own data? We have heard multiple variations and would like to hear what ACS would recommend for the entering of burn patients into our trauma registry. So several questions in that little paragraph. So the entry into the trauma registry will be based on your policy. In regard to reporting data for the PRQ, patients admitted to the burn service would not be reportable for the PRQ. However, burn patients with any associated traumatic injury should be captured in the trauma registry and should be included in the total trauma volume. So we have like 2 questions on hospice for this part. So when completing the death section of the PRQ, does the VRC expect you to report patients with a hospital disposition like hospice, whether that be house, in a hospital, or home with hospice, as a death in the hospital? PQIP defines hospice strictly as a hospital disposition, not a death. So for verification purposes only, not all trauma deaths discharged to hospice are required to be reviewed as a trauma death and counted in the trauma statistics. These patients may be counted as a discharge if the patient did not die while on the trauma service. However, if the patient was discharged or transferred to a hospital, inpatient unit, or to an external hospice facility, the expectation is that the care of the patient leading up to the transfer or discharge is evaluated through the PIPS process by the TMD and TPM. And if any issues are found, then it may be reviewed at peer review. And then the second question on hospice was, more information regarding the hospice would be great, i.e. if they were admitted to a memory care facility within hospice, does this count? So yes, this would be acceptable. The expectation is that the trauma program reviews the care leading up to the patient being transferred through the PIPS process by the TMD and TPM. If any issues are found, then it can be reviewed at peer review. So we have another question on the TMD. So can the TMD at another facility be the liaison for the ped surgery team? The TMD is still dedicated as the TMD at the level 1 ACS verified center. So the TMD from the ACS verified center may act as a pediatric liaison at your trauma center as long as his or her primary duties are not encumbered. With this said, the TMD cannot be on call at the same time for both trauma centers. The TMD must be dedicated to one center while on call. All right, I'm going to turn this over to Megan for the CD related questions.
Hi, everybody. Megan here again, and let's go through these CD related questions. So we're starting off with arrival times, CD28. A couple of questions on this one. Does the 30-minute arrival time for the OR start with the patient arrival / page or the notification by trauma surgeon? Are OR times tracked from decision to wheels in the door or decision to incision? So these are both for a level 3. The clock is going to start from the time that the OR is notified that a case needs to be done. And here's one on TMD participation. I could not find a CD related to mandatory participation in RTO. We think that is Regional Trauma Organization. If that's not what you meant, please let us know. But that's what we're told. Is there such a CD? So we're also implying that, or interpreting this as TMD participation, but if that's not what you meant, please let us know. But as per CD 5.8, membership and active participation in regional or national trauma organizations are essential for the TMD, so not necessarily all trauma surgeons, specifically just for the TMD in level 1 and 2 trauma centers. And this is desirable, so this is strongly recommended for TMDs in level 3 and 4 trauma centers. And examples of regional trauma organizations that you could join, regional or national, AAST, for example, EAST, the ACS COT, the Western Trauma Association, and the Society for Critical Care Medicine. So here's one on non-boarded surgeons, CD 6.3. We have a question regarding the last part of CD 6.3. This regulation states that if a physician has not been certified within the time frame by the certifying board after successful completion of an ACGME or Canadian residency, the surgeon is not eligible for inclusion on the trauma team. Such a surgeon may be included when given recognition by a major professional organization, for example, the American College of Surgeons. So if a surgeon is not board certified, but has been a fellow of ACS in good standing for some time, would they meet the criteria for recognition by a major professional organization? So the short answer is yes. However, if the surgeon in question is foreign trained, this would not be applicable. For more information about the foreign trained physician criteria, we're going to refer you to the alternate pathway document on the website.
Just really quickly, it's Molly, just a quick clarification on this, because I know we've had a lot of questions about alternate pathway. We have not presented them on the webinar, but we've had a lot of emails. Just to clarify this statement, this is just for U.S. trained physicians. And again, we haven't had a lot of physicians that meet this criteria. So if you have any questions about this and this is occurring at your trauma center, please contact us for more information to just make sure that it is compliant with the standard. You don't want any surprises during a site visit.
Thank you so much, Molly. All right, and with that, we're going to move on to a question on neurosurgery response time. Regarding CD 8.2, neurosurgery 30-minute response, can a surgical resident scheduled to cover neurosurgery qualify for a 30-minute, and we're assuming that's bedside eval. The intent is that the TMD and liaisons for orthopedic surgery or neurosurgery develop guidelines for which types of critical and complex injuries the orthopedic or neurosurgeon will be responding to. And when we say respond to, we do mean in person at bedside within the 30-minute time frame. So if they send the specialty resident or the physician's assistant or APP, there must be guidelines for the types of injuries that they are approved to respond to, and there has to be clear documentation of the discussion with the surgeon specialist on the plan of care. And again, on neurosurgery response time, is there any change to the neurosurgery response requirement? We did get a little bit into the chapter revisions process and how all of that has been going, but to clarify, there have been no changes at this time. We will certainly disseminate that information when it becomes available. And another on neurosurgeon PI meeting attendance, CD 8.13. In regards to CD 8.13, please clarify the requirements of neurosurgical attendance at the trauma, multidisciplinary, and peer review meetings. Does only the liaison have to attend at least 50% of the time, or do all neurosurgeons on the trauma call panel have to meet the 50% attendance requirement? So the requirement for neurosurgeons is a bit different from, say, CD 6.8, where all trauma surgeons have to attend at least 50%, and we do track that in Appendix 2. For neurosurgery, only the liaison or the predetermined alternate neurosurgeon need to attend at least 50%. And if the neurosurgical liaison is using a predetermined alternate, it has to be, as we've said before, one person, and their combined attendance has to meet at least 50% of the time. So again, this does not extend to all neurosurgeons on the trauma call panel. And here's one on the operating room team. According to CD 1115, criterion is met by having a complete operating room team in-house at all times for expeditious OR care for the trauma patient. Is it acceptable to have a primary OR team on call if response times are tracked for compliance? So the requirement is for the OR team to be available within 15 minutes for L1, L2. The best method to meet this requirement is to have an OR team in-house. That's the best way that you can satisfy this criteria. With that said, if the trauma program can demonstrate to the reviewers on site that the OR team is assembled within 15 minutes with an on-call team outside the hospital, then this would be acceptable, but that must be met 100% of the time. And here's another one on OR response time. Is allowing the on-call OR team 30 minutes from notification to arrival too long? And this is from a level 3 center. So as we discussed in the last slide, so for level 1 and 2 trauma centers, the OR response requirement is 15 minutes. For level 3, this extends to 30 minutes. So based on what you're describing, a maximum of 30 minutes from notification to arrival would be appropriate. Here's one on interventional radiology. IR response time of 30 minutes is the response time calculated from initial call to radiologist arrival, or rad phone response to arrival. So the interventional radiologist is not required in-house 24/7, but they do have to be present at bedside, and again, we're going to stress at bedside, within 30 minutes. The clock for this response will start when the request or call is made, and the clock will stop when the radiologist arrives at the patient's bedside. And another one on interventional radiology regarding CD 1133 and 30-minute IR response. Which complex imaging and interventional procedures require 30-minute response by IR? So the ACS does not actually define the types of complex imaging and interventional procedures. This is going to be determined by your institution, and basically the reviewers will be confirming that you are meeting your own criteria. Here's one on surgical specialists. Define what available means for the different specialty service providers at a level 2 center. Does this mean 24/7 call? Does this mean transfer? So the surgical specialties, microvascular, vascular, and so on, are not required in-house 24/7. The big thing that we want to confirm is that there is a surgeon consultant available to respond in person, again, when requested by the attending surgeon within a predetermined time. The trauma program must be able to demonstrate who is providing the coverage when requested, and transfer agreements are acceptable for complex injuries. Here's one on the ICU nurse ratio. CD 1166 patient-nurse ratio in ICU must not exceed 2:1. Is this for the entire ICU or only those nurses caring for trauma patients? So the patient-to-nurse ratio of 2:1, that's going to be for trauma patients in the ICU and or waiting for an ICU bed. The guidelines for patient-to-nurse ratio in these instances are going to be determined by each individual trauma center. And a couple on trauma registry, CD 156. If registry has charts not closed from 2017, but current data year 80% is closed within 60 days, are there consequences? And are charts to be closed within 60 days of discharge? So for the reporting year, and that's what we're going to be focusing on is the reporting year, the expectation is that 80% of the cases are closed within 60 days of discharge.
This is Molly. Just a really quick clarification. Earlier in the presentation, someone had asked, we reported that there's a call for data and they are collecting some data for 2017. So for this particular person who submitted this question, you want to think about your registry for 2017, and if it's not closed, that may impact your TQIP data that you're going to submit. So again, you may want to go ahead and check with the TQIP team on that at tquip@facs.org, or you can just shoot us an email, COT-VRC@FACS, and we can help you with that information and how best to close that information from 2017. But just keep in mind that that may impact your data submission to TQIP.
Thank you so much, Molly. And we have one here on alcohol screening. We have a group of patients that have some type of traumatic injury that our trauma team does not treat or consult. We track them through our trauma database. Is this group included in the SBIRT compliance of 80%? In other words, do these patients need to have a blood alcohol level done and SBIRT if they test positive? Thank you. Yes, short answer is yes. So long answer, if the patient was still admitted with a traumatic injury and included in your admission numbers, Even if they went on to be treated by a subspecialty such as neurosurgery or orthopedics, any of those patients would be considered, that would be considered alive and participatory, so not comatose, not severe altered mental status, etc., would be included in the 80% minimum for SBIRT. So any such patients who receive a positive screen must receive an intervention. And a few quick questions on CME. CE credits. Do trauma registrars need trauma-related continuing education credits? If so, how many? So there are currently no requirements regarding CE credits for trauma registrars. We do have one for a requirement for trauma program managers, but not at present for trauma registrars. The Orange Book provides a recommendation of a minimum of 8 hours of registry-specific continuing education per year. And another one, we had a new TMD takeover in October of 2018, and they have a site visit coming up in September of 2019. Will they have to have the full 32 hours of CME, or is it prorated? So yes, the required amount of CME would be prorated based on the TMD start date. So on site during your visit, the reviewers would be looking for a minimum of 12 hours of CME total just to cover that surgeon's first year. And one more, regarding CMEs and CEUs, are these webinars, verification and TQIP, offered by ACS, COT, VRC, considered as trauma-related CEs and can be counted towards the required CEs for the TMD and the TPM? So to clarify, the TMD has to have 12 hours per year of CME, which is separate from CE. As such, the TMD would not be able to use viewing these monthly webinars to count towards their CME requirement. So for the TPM, however, the education requirement for the TPM is 12 hours per year of CE, meaning that viewing the monthly webinars would count towards their total. So you're welcome. And that's all we have for today. Thank you guys so much for joining us, and see you next month.
Thank you, Trauma Verification staff, and thank you everyone for attending today's webinar, Trauma Verification June Q&A Web Conference. If you have any other questions, please contact cotvRC@facs.org. On behalf of Trauma Verification and our presenters, thank you for joining us today, and have a great rest of your day.